Well, good afternoon, everyone. It's really a delight to be here at the outset of the Partners World Medical Innovation Forum. Anne just introduced me. I'm Susan Hockfield, President Emerita of MIT, but I'm a trustee of Partners from a position that I get to look out across the entire enterprise. And there are few as interesting activities that are going on than this as we sit on the brink of artificial intelligence. As many of you know, I'm an avid advocate of cross-disciplinary and cross-institutional practices. And I would say that today there is no more promising cross-sector technology than computation in its current incarnation as artificial intelligence. So our topic, AI strategy, AI from the top, could not have greater potential and could not be both more pressing and more puzzling. Almost every description of every activity now includes AI, whether it obtains or not. And it seems like everyone in all of our institution wants to use it in some way or another. Today we have some local experts to help us start the forum's conversation, focusing on two key themes, and these are themes that Anne has just called out. What can we expect AI to deliver in the near term? What are we delivering now, and what can we expect over the next year or two? What's almost in our grasp? And then what is the role of the top? That is, how can central structures, central resources, and central support help and not hinder the future of AI in health and healthcare delivery that we all dream of? So I'm going to ask our panelists to briefly introduce themselves, and then we'll get started on our conversation. Keith, why don't you start?
Thank you, Susan. Hi, I'm Keith Dreyer. I'm a diagnostic radiologist, been at Partners for about 24 years. I'm the Chief Data Science Officer and more recently the founder of the Clinical Data Science Center.
Hi, my name is Alistair Erskine. I'm a pediatrician and internist. I'm Partners' Chief Digital Health Officer. I recently joined Partners, and I have responsibility over the digitization of our clinical workflow processes.
Hello, I'm Gregg Meyer. Thank you for joining us here at the forum. I'm a general internist and primary care physician, and I also serve as the Chief Clinical Officer of Partners, where I oversee our work on population health management, digital health, our enterprise health record, as well as our data and analytics, so much of the raw material for artificial intelligence. And I also have the privilege of serving as the co-chair of the forum this year.
Terrific. So there's lots of enthusiasm, and I've actually heard this word used before. I'm using it today. Some would say hype about what AI can deliver. To set the foundation, I want all of us to hear from you a sense of what you see, where we are today, and what's happening now either at your institutions or elsewhere that you know of. And importantly, what should we expect to see in the very near term, say in the coming year or two? Gregg, do you want to start? We'll just kind of run down the line from you.
So there's certainly a lot of hype out there, but I think that what's different, even when I look at a year ago when we had these discussions, there are some incredible things going on out there. There's a wonderful example that I came across on the Africa Health Research Institute, a group that is a collaboration between the University College London and the University of KwaZulu-Natal in South Africa, which has mobile vans, which actually are traveling around the countryside in rural South Africa, which take x-rays of patients or potential patients for tuberculosis. What they've been able to do is they've been able to embed AI into looking at the images that they're collecting and in real time providing feedback to say TB or no TB. And in fact, when they do see that a patient has TB, they can go ahead and initiate treatment. The notion that we can leverage this tool to democratize access to expertise and also improve incredible convenience to patients and bring them care where they live, that's amazing. So there's hype, but there's some real amazing things going out there.
Alistair.
So I think that the favorite part of taking care of a patient is spending time with a patient, and there are some parts of taking care of the patient that involve documentation or writing a note. And back in the paper days, the promise was that we were going to digitize that process. And we went from paper to electronic notes But that was accompanied by a bit of an unintended consequence. And the unintended consequence was something that is now being termed as an industry term of burnout. And so as we work our way into this deluge of data that is necessary, that is a currency for AI to be able to do what AI does, we're trying to find other ways that we can actually perform the documentation, taking advantage of all the previous examples of documentation and to help that process. And it's an interim step that we're doing right now, which involves recording the session and then having a human actually translate that session and return it back to the clinician. But what's already happening with companies like Nuance and others is that that transaction of converting what is being said and what is being recorded into something that ends up into a discrete clinical note is now using the tools of AI to perform real-time processing of that information so that that clinical note not only ends up being accurate representation of what's going on with the patient, but also addresses the burden associated with documentation and being able to capture that appropriately.
Keith?
Thank you. So there's clearly hype, and the question is, where does it come from? I think the world is flat enough today that you can't get away with hype without anything behind it. And so what I'll see again and again is somebody produces a research discovery where they announce they've actually been able to do something maybe superhuman or equal to human. And if you look at it, it is true. But the real question for AI is, and the challenge is, if you can make that happen in a lab, can you make that happen everywhere? And then we start to get into other interesting topics like bias and depth of data and the ethics around it. And some of the challenges I think that we have today in any industry, but in healthcare in particular, because it's so appropriately regulated, that how do you allow this new concept to be able to grow into our space? For example, the great example that Gregg gave about using AI to look at TB images from chest x-rays to look for TB. So now you can use what's called TensorFlow.js, and you can make that inference run inside the browser. So I could, in theory, hold my camera up to a chest x-ray and get the answer back of TB, no TB. Now, how do you handle hundreds of ministries of health to be able to control and regulate that, unlike the way that we do with humans today, because it's not the same. The model's different. So my fear is, in some ways, I've seen stuff work that's absolutely amazing, but I've seen it slow to penetrate the marketplace. And so there's a perception of hype. There's a desire to tell the story that this is amazing because it really is in certain situations. But the question is, how does it scale and how does it go broad? And if it doesn't go right away, is that considered just to be hype and not reality? That's the challenge that I see again and again.
So that really leads to this next question. So you all report that we've got a running start, and whether it's a running start that just hasn't figured out how to permeate all of our activities, but there clearly are really, really interesting and promising things going on. But I think what we have to monitor, Keith, is this issue you brought up, which is, how do we measure how we're doing? So what have we learned? What are the things that we can do and should do? And what are the things that we can't and probably shouldn't do? And more importantly, or more explicitly, what are the pitfalls and challenges in AI, including some of the kinds of ethical and bias issues that come out in AI that we really haven't had to experience in the analog world? Yeah. So, Alistair, you want to start on that for us?
Sure. So, one interesting thing is, of course, AI is dependent upon the data that underpins it. And one of the things that has become clear is, dependent upon the source of that data, it can dramatically, in fact, impact the model that you end up building. So turning to what MIT was able to demonstrate just this past year, they came up with a character called Norman. And Norman was trained on purpose as being a bit nefarious. And what it was done is it was fed a data set to interpret ink plots. These are these psychiatric plots that are designed to be able to elicit how somebody thinks about something. And Norman was basically taught how, given a set of data and shown that if you can take these ink plots and show them to Norman versus a regular person, you can see how biased and how he can take something that looks like a set of flowers and turn it into something which is actually much more nefarious than that. And I think the purpose of that demonstration was to really kind of highlight the risk that's associated with how you gather your data, then how you test your data, and how you make sure that the answers that are coming through, especially in both the interpretable and the non-interpretable ways, if the answer you're getting is actually what you're looking for. So it brings up and introduces the idea that identifying within one data set important insights sometimes have to be retested in data sets that are parallel or in other locations or across other different genders or across the planet before you can refine that. Otherwise, it introduces potential bias. And the decisions that are coming out, especially the ones that have an impact on the intervention that you're going to do, are important.
Keith?
Yeah, I would say that if you're a researcher and you're creating AI and you want to get out quick and you want to have high accuracy, what do? Well, one of the things you could do is decrease the amount of data diversity. So you could narrow down the AI to focus in a certain area. In my field, in radiology, you do that. You might say, I want to focus on just one particular modality like MRI, or maybe one scanner, or one slice thickness, or one pulse sequence. And as you start to narrow that down, the accuracy should, in theory, go up. But when you do that, you make it so that it's biased toward that solution. Well, if you think about that with demographics, you could do the same thing. And I think we're doing that sometimes without knowing what we're doing. So I think one of the challenges that's missing, or one of the solutions that's missing in AI is, we're to the point now where we do pretty good at making narrow AI, but how do we implement that AI? And then after we've implemented it, and I'd say we do a terrible job of that today across the healthcare field, how do we monitor it? So what is in place to make sure that if that AI changes and gets quote unquote more accurate as it learns, how are you able to regulate those kind of activities that are happening everywhere and to monitor for bias and to be able to look for those kind of things? It's just too new of a field to have all those answers today.
Gregg.
Yeah, I think among the lessons is that we really need to go back where many of us started our lives as researchers, and we learned how important it was to not just focus on the intervention, but also really focus on the control group. And that notion of let's ensure that the control groups that we're using to help develop these algorithms and the deep learning and using tools of artificial intelligence, that we're making sure that they're representative. I'm also concerned with thinking very clearly about the purpose for developing algorithms. I'll give an example that Dr. Klubansky and I have the pleasure of chairing a committee, the Clinical Data and Tissue Sharing Committee at Partners Healthcare, and we get to review some amazing proposals on what's going to be done with our data to help use artificial intelligence to drive better decision-making, better care for patients. And one of the proposals that have come our way in several different forms is the notion of being able to look at children's faces, to take pictures, and to be able to, from facial physiognomy, to be able to actually start to pick up very nuanced differences that can help lead a clinician to come up with a diagnosis of a particular syndrome, hopefully with some therapeutic implications. And that idea that we can actually take that tool and help an average physician become an amazing physician at being able to discern those characteristics, that's terrific. On the other hand, there's a pretty fine line between artificial intelligence becoming the calipers of the 19th century and the dark history that went along with them. And so it's really thinking really hard about what purpose we're trying to achieve.
So each of you has kind of alluded to this, but I don't really think either of you has really hit this nail right on the head. So one of the concerns throughout the whole population about AI is an issue of privacy. And so obviously in the medical world, we have been very focused on patient privacy and who owns patient data. I think AI turns this whole concept in a very different direction. So as you all, as practitioners, think about the potential of AI, how do you think about the privacy issues that have taken us a long time to put in place for analog medicine?
Well, I think it's challenging because it's so new. So you raise the exact right point. The question is, one, as challenges happen and arise, I don't think these questions, these ethical questions that you raise, are going to be tried in the courts. They'll be tried in the courts of public opinion. What is the right thing to do? What is it on our patient's behalf that's the best thing to do? If I could bring in DNA sequences from all of you and create a solution to a diagnostic problem, is that the right thing to do? If I gained your consent, is that the right thing to do? These are the ethical questions that we have to ask. And as making these decisions, it's important to be able to have secure data and patient data that we monitor continuously. So the interesting thing about artificial intelligence is as you bring all of the data together and as you create these weighted algorithms, these abstractions, you've by default anonymized a lot of the patient data, but you're still using patient data. So these are the questions that everyone's asking today. There's not a lot of governmental regulation on this today. There's a lot of white papers being discussed appropriately as we need to. But again, you can think of it as another appropriate throttle that's being put there to actually make us really ask what's the right thing to do.
And I would remind you, there's a study at MIT showing that anonymized data can be very easily de-anonymized. So,
correct.
Greg, your thoughts on privacy?
Yeah, I think what we need is nothing short of a massive public education campaign about data and about privacy. And that is to make sure that people have the ability to understand not just the downsides, but the upsides as well as contributing their data to these efforts. Because what I see as a macro trend here is there are many organizations around the country, and Partners Healthcare is privileged to be one of them, which have been stewards of data over time. But that data is now very quickly really going to be controlled by patients directly, by the public directly. And so to me, these are not unsolvable problems, but we need to have a very open public conversation, and that needs to begin with a very, very broad education campaign.
Yeah, Alistair, please.
So, and you know, the other piece, based on what Gregg is saying in terms of how we're doing with who owns the data. The data is owned by the patient. I think that is coming to be a de facto. We're stewards of that data. And just in the same way that Willie Sutton said, you know, why do I rob banks? That's because, you know, that's where the money is. We're stewards. You know, why do we come to healthcare organizations? That's where the data is. And I think that more and more we have a responsibility, especially when it comes to identifiable data. But the models that come out of AI, driven from whatever ends up in the electronic health record, that is a derived format. And the model itself is really a manifestation of that data. It doesn't have components of that data in it. It's a model, and it's a model that gets to be applied with some difficulty at times. And that model, which is one of the key aspects of it, which is going to be challenging, is when done properly, continuously and constantly changes. And it changes in a way that it's hard for a regulator to wrap their heads around it, because it's one thing to have a locked model that just doesn't change, but then it doesn't continue to learn. We want to learn in health system that enables us to constantly make sure we adapt to the new patients that are informing that model. So I think there's this tension that exists between the privacy of the patient data at the individual level and this ongoing model that keeps on changing and refining itself over time.
We may come back to this privacy issue because I think there are a couple of other domains that we haven't really explored yet. But before we get into all of our deep concerns, let's first take a look at the distant future, or the more distant future than 2 years. And so the Longview, what do you foresee over the next 5 or 10 years? And what are the innovations, the AI-based innovations that we can anticipate in both the clinical domain as well in healthcare administration? Keith, you want to start?
So what's happening in the short term? Mm-hmm. So today, what seems to work well is, as I mentioned, narrow AI. So as you look at the architectures for machine learning today, they're somewhat nascent. They've been around for a while, but they've really been able to handle large amounts of data like this most recently because of the computational capabilities. So that means that you tend to focus the problem on focused areas so that you can get high accuracies. So now you have solutions that are coming out that are high accuracies for specific areas. How do you create specific areas? Well, you need what's called ground truth. So you need to train this algorithm to say, here's an image, say for example, and this is cancer, no cancer. And you do it again and again and again. Well, how did you find out there was cancer, no cancer? Either a radiologist said there was, a pathologist said there was, a biopsy said there was, so there's what's called ground truth. So today, what's working well is that you can replicate that which a human does, because the human creates the ground truth. That's interesting, that's exciting, that's revolutionary. It really is, because we only had human intelligence to do this before. But what could happen next? You could start to ask questions that humans cannot answer. So now you can start to look at things and discover things through unsupervised learning instead of supervised learning, and be able to discover things that humans don't have the ability to. Now the question is, how do you explain that to a human? What's the explicability? How do you prove to the humans that have to make the physical decisions that this artificial intelligence solution is telling you something that you know to be true? And so I think the 5 to 10 year horizon, while it's going to be greater breakthroughs, are going to create even more challenges like the ones that we're discussing here early on as to how to manage all of this intelligence that's going to be coming at us that we don't even have today.
Alistair, what do you see coming down the pike?
I'm looking forward to the easy button. And let me tell you what I mean by the easy button. What I would like to be able to do in real time is when a patient comes in with a certain diagnosis into the hospital, for example, I want to find out every other patient that's like them throughout the entire history of my data repository. And why do I want to do that? I want to do that because half of the way that I treat my patient is using evidence-based medicine. But a lot of the way that I treat my patient is using heart, and he's using gut, and he's using things that don't have evidence. But in fact, that evidence does exist. It's embedded within the bowels of the data that we dutifully type into the computer today. And if there was a way, and in fact with AI, in 5 to 10 years, it's conceivable, that as soon as a patient arrives in the hospital, that there is a list of patients that are like them, that I can see actually how they were treated and what their outcomes were. Then I'd be able to be in a position where I can reconcile and adjudicate what I know is evidence and what I don't know yet because it hasn't been proven in terms of what that outcome in that patient is, so that I can pick the best treatment possible. So the easy button lets me pick and see how other patients have fared with the treatment plan to be able to manage their condition, get the right interventions, and get to the right outcome, which is what we're looking for, but organize it in a way that I don't have to spend bazillions of clicks trying to go and identify and find. So I think the easy button's coming.
So it's a way of actually expanding what doctors have always relied on, their personal experience, by all of the experience of all the doctors whose patients are in your data set. That's a great ambition. Gregg, what do you see in the future, near future?
So I'm always the optimist, and in 5 to 10 years, I'm hoping that we move from what are piecemeal applications to actually supporting workflow. Now, let me give you an example of where I hope we'll be. Right now, before I see a patient, I often will sift through the chart and I'll try to find relevant data and look up the facts from the last visit. I'll then see a patient, and afterwards I'll then put in information to do some billing, some documentation, and maybe a few days later check up on some lab results and communicate with the patient. It's an incredibly inefficient process, and by the way, in that middle part, I'm spending a lot of time when I'm with the patient putting data in. I do think in 5 to 10 years, we could be in a really different place. We could be in a place where, in fact, before the patient comes in to see me, that the artificial intelligence applied to the electronic health record has sifted through the information, has pulled up the most salient points that I need to address when I have that patient encounter, so I move from being reactionary to anticipatory. That then, during my time with the patient, I'm using voice recognition and other tools to help do the documentation. And on the back end, all of that work on the administrative healthcare, again, is being facilitated and taken over. So we talk now about how dehumanizing the electronic health record has been to healthcare, and we all feel it. But I actually think in 5 to 10 years, we might capture the opportunity to use artificial intelligence to rehumanize healthcare, to actually give me the opportunity to really be there with the patient, not sifting through things, not worried about filling out the billing forms, not worried about monitoring that follow-up lab, but be with the patient, talking about their illness and working with them.
That's also a beautiful vision. So let me now come back to the title of this session, which is at the top. And so the question that really haunts us in all of these big organizations is what can the top do? What can central administrations actually, how can central administrations add value to these very, very difficult and emerging technologies? You know, often, you know, the advances happen one by one, kind of mom and pop organizations or cottage industries where one part of one hospital will be doing something that looks kind of good and different activities going on someplace else. And, you know, how do we gather up those resources so that, you know, everyone can benefit from the kind of innovations that are happening globally in ways, of course, that benefit our patients? So the real question, I think the way I think about it is, what can the center do? I don't like to call it the top, I like to call it the center do, to help the whole be more than the sum of the parts. And you know, what are opportunities for us to actually gain advantage for all of us, and not just, I'm not talking about economic advantage, but I'm talking about real healthcare advantages for our entire, you know, community and the nation. So what's the role of the top? What's the role of the individual practitioners? Alistair, do you want to start us on that one?
Sure. I think that you know, the role of the top is to look for the USB port to the data. So
you have to explain that.
So let me explain what I mean by that. So you know, if you go to healthcare systems around the country, the way that the data is organized is different every single place you go. So let's say I come up with a really intelligent algorithm that I'm going to want to use around the entire globe in order to be able to make sure that whatever value from that algorithm is being able to be utilized elsewhere. Well, the challenge ends up being not the AI model building, but so much more of the work is in the data management piece and then in the implementation piece. And why is it so hard? Because there's not a USB port that I can plug my algorithm into that I know it will work in the same way everywhere that I plug it into. And part of that is because there's not universal data models for healthcare. Part of that is because the transactional systems are all competing and different. And part of that is because the workflows in one hospital are going to be different than the workflows in a clinic in another hospital. So I think that one of the roles is to think about, all right, how do we create a scalable infrastructure that is able to then absorb the data that is necessary, both consider traditional data today structured, less traditional data in terms of unstructured data like clinical notes, and even less traditional data in terms of, you know, Internet of Things and waveforms and so forth that actually make up the picture of that patient. And then how do I make sure that that is able to work its way into the model that is being distributed at scale and derive the value to everybody elsewhere?
Keith?
Yeah, I agree. I think we've done a good job over the last 30 years or so structuring the data. So if you think way back in the 70s, 80s, things were on paper, and now we put our data in organized fashion. And there's pluses and minuses to say about EHRs, but the data is at least there and it's structured. Now, how does intelligence get structured in healthcare? Well, there's departments, right? And we have human intelligence that's segregated into these different groups that make these decisions. We have not even contemplated how to manage information or knowledge inside of that domain like data. And so we're just starting into that space. So if we had 5 algorithms and they ran on certain data elements, we'd know what to do. But what if there were 5,000 and they ran on all different aspects of data elements? And they were meant to get some data and give answers to clinicians, give answers to patients. What if they could go out and get social determinant data off of patients and pull that data in and make further decisions? We are nowhere in the notion of being able to manage that massive amount of information and coming from different places as knowledge today. So I think we all need to start thinking about how we, one, if we haven't organized your data, you clearly need to Alistair's point, you need a clear way to be able to get that data out. But then you need to think about how do you handle this information that we're creating, this intelligence that we're creating, that we need to intercommunicate inside of a facility. And then the big question is, how do we move that information around, that intelligence around, so that if we make a discovery, someone else can quickly pick up on that elsewhere in the country, elsewhere on the globe.
Gregg?
You know, I think about the role of the center, the role of the top in terms of trying to direct us to improving healthcare with AI. To me, it was very clear, if you had a chance to hear the first look people this morning, the innovation is going on with people at the front line. And so I believe that the role of the center is to try to put together the tools and the data, to organize it in a way that is useful, to help identify the important questions that we need to answer, for example, from a health system or a societal level, and then, frankly, to facilitate those at the front lines to do really amazing things on the front end. And then on the back end, the role of the center is to be able to evaluate those which are making a real difference and then spread them. And that's the real challenge, is that last bit, is the spread.
So I would only add one piece to this, which is that if we can empower all of the people who live and work in our organizations to be able to innovate on top of the tools that we provided them, so that we don't give them a closed box, but we give them an open box where they can add USB ports and put data in and come up with new ways of using it. I think that is a perfect kind of balance between the center and the periphery. So I want to thank you all for giving us a very optimistic view of the near future and an even more optimistic view of the distant future. And frankly, thank the three of you for your leadership in helping the partner system get there in time to save more lives and give us all more joy in our work. Thanks very much.
Thank you. Thank you.